On October 2, 1918, a silent killer slipped into Camp Funston, Kansas, and within weeks it would claim more lives than the battlefields of World War I. In a world already bruised by 4 years of global conflict, a microscopic virus surged across continents, turning bustling cities into ghost towns and leaving a death toll that eclipsed the 17 million war dead. This is the story of the Spanish flu pandemic, an invisible enemy that struck without warning, reshaped societies, and taught medicine its most humbling lessons. The world in 1918 was already a tinderbox. Troops crammed into cramped barracks, soldiers crisscrossed oceans in steel-hulled ships, and the movement of men and material created a perfect conduit for pathogens. The H1N1 influenza, a virus, later identified as the culprit, likely originated in the rural provinces of China before hitching a ride on the Western Front. By the time the armistice was signed on November 11, the virus had already claimed millions in Europe, Africa, and the Americas. Unlike the familiar seasonal flu, this strain was unusually lethal, striking down healthy adults in the prime of life with a ferocity that stunned doctors. What made the 1918 pandemic so deadly was a perfect storm of viral genetics and human circumstance. The virus possessed a hemagglutinin protein that bound strongly to receptors deep within the lungs, causing a rapid cascade of inflammation known as a cytokine storm. In young, robust immune systems, the reaction was often fatal. At the same time, the war had displaced populations, depleted medical supplies, and forced crowded living conditions in trenches, ships, and refugee camps. Public health infrastructure, already strained by the war effort, could not keep pace with the virus's relentless march. Key facts paint the sheer scale of the disaster. Between January 1918 and December 1919, an estimated 500 million people, roughly a third of the global population at the time, were infected. Official death counts vary, but most scholars agree that between 20 million and 50 million lives were lost, with some estimates soaring to 100 million. In the United States alone, 28 million cases were reported, resulting in roughly 675,000 deaths. The mortality curve was unlike any previous flu pandemic. 3 distinct waves, the second, the deadliest, striking in the autumn of 1918, just as soldiers were returning home. Rural communities suffered disproportionately, where medical care was scarce and misinformation spread as quickly as the virus itself. The response to the pandemic was a series of rapid, often improvised public health trials. Cities that had survived the first wave, such as Philadelphia, were caught off guard when a massive parade on September 28, 1918, drew 500,000 spectators. Within days, hospitals overflowed and makeshift infirmaries sprang up in schools, churches, and even private homes. In contrast, St. Louis instituted early school closures, banned public gatherings, and enforced mask mandates, resulting in a mortality rate that was a fraction of Philadelphia's. These divergent outcomes became early case studies in the efficacy of non-pharmaceutical interventions, lessons that echo in modern pandemic planning. Medical professionals, desperate for a cure, turned to the limited arsenal of the era. Antiseptic sprays, quinine, and even bloodletting were tried with little success. One of the most infamous experiments involved the administration of tartaric acid and iodine tincture directly into patients' throats, hoping to neutralize the virus on contact. Meanwhile, a handful of physicians attempted convalescent plasma therapy, transfusing blood from recovered patients into the sick. Though the practice showed promise, the lack of standardized blood typing and sterile techniques limited its impact. In many hospitals, doctors were forced to make heart-wrenching decisions, allocating scarce ventilators and oxygen to those most likely to survive, a grim precursor to the triage dilemmas of later epidemics. Autopsies performed during the pandemic revealed the true horror of the disease. Pathologists in Chicago, London, and Buenos Aires reported lungs that had turned a deep, hemorrhagic red, weighed twice their normal mass, and were riddled with fluid and inflammatory cells. The classic description of white lungs, a frosted appearance caused by fluid-filled alveoli, became a hallmark of the disease. In many cases, the virus had triggered secondary bacterial pneumonia, which compounded the damage and made the lungs appear as though they had been set ablaze from within. The meticulous work of these early autopsy teams not only confirmed the viral nature of the illness, but also laid the groundwork for modern pulmonary pathology. The aftermath of the Spanish flu reshaped societies in profound ways. Economically, the pandemic stalled post-war recovery, costing the United States an estimated $2 billion in lost productivity, a figure that dwarfed wartime expenditures. Politically, the crisis accelerated public health reforms. The United States established the Division of Epidemic Intelligence within the fledgling Public Health Service, while many European nations codified mandatory reporting of infectious diseases. Socially, the pandemic left a cultural scar. Literature, art, and cinema of the 1920s often carried themes of loss, fragility, and the uncanny power of unseen forces. Yet the most enduring legacy lies in the lessons it taught medicine. The 1918 experience underscored the importance of surveillance, rapid data sharing, and coordinated public health response. It highlighted the need for robust laboratory capacity, a demand that spurred the development of virology as a distinct scientific discipline in the decades that followed. The tragedy also reminded the world that viruses respect no borders, and that preparedness is a perpetual race against evolution. Subscribe to the Autopsy Files for more stories like this.